Welcome to Defining Health Equity. My name is Stephen Collins. I'm the CEO of Matter. Matter is a healthcare technology incubator and innovation hub that's built on a belief that collaboration between entrepreneurs and industry leaders is the best way to develop healthcare solutions. Today's program is the first event in a new series on advancing health equity. Over the past year, the inequities that have really always been a defining feature of our healthcare system have become significantly more apparent to everyone. With this series of conversations that we're kicking off today, we will bring together decision makers and thought leaders to discuss the role that innovation and technology play in shaping a more equitable future. We are delighted today to produce our inaugural program with the Healthcare Council of Chicago, which is an organization that Matter launched together with Third Horizon Strategies. HC3 is an action-oriented collaborative that brings together leaders from across the healthcare ecosystem to develop and advance uncommon solutions to the health problems facing Chicago's communities. I know Megan Phillip, the executive director of HC3, is with us today, and just want to thank her and the organization for your leadership and partnership on this effort. For our conversation today, we are joined by two uniquely positioned leaders in Chicago to discuss technology's impact on health equity and really set the stage for us for the rest of this program series. Dr. Allison Arwady has served as commissioner of the Chicago Department of Public Health since January of 2020 and has broad responsibility for making Chicago a healthier city. Little did she know in her first 15 months on the job what it would look like. And importantly for the conversation today, equity is on her mind all the time as she grapples with the pandemic as well as with the other health challenges facing the city. Leading the conversation today with Commissioner Arwady is Dr. Helene Gayle, who is the CEO of the Chicago Community Trust. The trust is a 100-year-old foundation with more than $3.5 billion of assets and makes around $400 million a year in grants to support priorities in the Chicago area. Dr. Gayle has led the trust since 2017 and has made the organization a leader in focusing on helping to close the health equity gap in the Chicago region. So with that, we're going to hear first from Commissioner Arwady, and then Dr. Gayle will join in to lead the conversation. So Dr. Arwady, take it away.
Thanks so much, Steve. And thank you first to Matter and to HC3. And of course, I always love any opportunity to be in conversation with Dr. Gayle and appreciate Chicago Community Trust. And I'm looking forward to this conversation because I love talking about health equity with people who maybe don't think about it every day. And we've really benefited from partnerships with people who think about technology and think about innovation in ways that might not be the obvious way I would think about it. I spend my day at the Chicago Department of Public Health thinking about health in the broadest sense. But when we think about how do we move to an equitable society, that isn't actually as much about health care as you might think that it is. So let me back up just a little bit. The Chicago Department of Public Health is the local health department for the city of Chicago. And that means that we have the responsibility to try to make Chicago as healthy as it can be. And many people, when they think about what does it mean to be as healthy as they can be, the first thing that comes to mind is access to health care. Do I have a doctor? Can I pay for medications? Can I get care in an emergency without worry for lack of insurance or other known barriers? And certainly access to healthcare is an important part of being able to be healthy. But if we really think about public health more broadly, and also what health equity means, we have to think beyond access to health care, because really what makes Chicagoans and really all people healthy is less about access to health care and more about the decisions that society, cities, states, countries, and international settings, more about the decisions we make that help eliminate barriers to being healthy. And so health equity at the most basic level to me, it means that we've got a society where everyone has a fair and a just opportunity to be as healthy as they can be. What does that mean in practice? It means that we, again, broadly as society, not just government, but all of us who are working and have a real interest in promoting health, think about what are the obstacles to health. And that includes things like racism. That includes things like poverty and discrimination. And that includes things like their consequences, when people don't have power, when people don't have voice, when people don't have access to things like housing, or are living in environments that are not healthy, don't have economic opportunities, don't have educational opportunities. And these more root causes, sometimes what we call the social determinants of health, end up having an even larger impact in some ways than access to healthcare itself. And so at the health department, every 5 years, we have to do a community health improvement plan where we talk to partners and we look at data and we say, how should we prioritize our work for the next 5 years? And so about 11 years ago now, we first put together in Chicago what we called Healthy Chicago, which was defining, here are the metrics that we're going to follow, the health outcomes and indicators. Let's be specific about how are we going to measure health as a city. And we laid these out and we started defining within sort of our programs and with our partners, how are we as a city going to move toward these very specific data goals. And that was really important in terms of starting to frame how are we going to count success. And we said, we're going to be successful if Chicago overall is making progress on these indicators. And then about 6 years ago, it was time for our next community health improvement plan. And we said, you know what? As opposed to just how is Chicago going to be healthier, in what we called Healthy Chicago 2.0, we first started specifically calling out health equity. And by that, we said, okay, here's 75 or so indicators that we're tracking that show whether Chicago is healthy. What percentage of people are smoking? What percentage of people have are spending a large amount of their income on paying for housing? What percentage of people have health insurance? What percentage of people have HIV, et cetera? And we said, we're not just going to define if as a city, are we making progress on these? We said for each of these indicators, we're going to look at our data and say, which is the group that is the biggest outlier in terms of being able to meet sort of a healthier state. And so depending on what the outcome was, those root causes and some of the obstacles to health sometimes are rooted in things like race or ethnicity or whether people have disabilities, and then certainly whether people have access to resources. And so for some of these outcomes, like HIV in Chicago, Black Chicagoans, much higher rates of HIV. If you look at access to health insurance, Latinx Chicagoans, and particularly, Latinx men between, I think it was 25 and 44, by far the least likely to be uninsured. If you look at smoking, it turns out LGBTQ, much higher. If you look at bullying, right? And so this idea of how do we look at data and define which group, which might be a neighborhood, it might be a race, ethnicity, it might be an age, is the furthest from the mean. We are only going to consider ourselves to be successful in moving toward a healthier Chicago if those groups that need more supports and more resources are able to move closer to the goal. And that was defining really under Healthy Chicago 2.0. And then for our last round, about a year ago, we laid out Healthy Chicago 2025, again, with about 600 partners across Chicago. And for Healthy Chicago 2025, we said we're going to keep the focus on equity, meaning this is all about not equality, not making sure that all of the city has equal access, but about recognizing that there are parts of this city, geographically, demographically, that need more supports, and that we should be over-directing resources because there are more barriers to health in those groups. And so we specifically said, in addition to health equity, we're going to keep following those, but we're going to be focused even more on the racial life expectancy gap in Chicago, and really very explicitly calling that out, and the structural racism that exists throughout the society, and wanting to think about what can we practically do together as a city to address the fact that not everybody has equal opportunity to be as healthy as possible. And so we looked and said, what are the 5 main drivers of the life expectancy gap in Chicago? And across all of Chicago, no matter where someone is living, no matter what their opportunities, Black Chicagoans live almost 9 years less long than other Chicagoans. And we could talk about some of the other groups. And the biggest gap, the biggest drivers of those gap, number one by far is chronic diseases. So that's your diabetes and your heart disease and some of the cancers that are more chronic. That's more than half of the gap right there. And then in terms of the other 4 that were driving that gap, next came gun-related homicide, followed by infant mortality, which is actually known to be one of the most sensitive indicators across the whole world in terms of how healthy a society is broadly. Number 4 was HIV and other infectious diseases. And then number 5 was opioid overdose. And so first, as a city, we want to keep a focus on these proximal outcomes. But then we said, what is actually driving those? Why do people have different rates of chronic disease? Why do people have different rates of opioid overdose? And that's where you start getting into the real work of health equity. And it's about saying, what are we as a city doing to promote more equitable access, propping up the ability, recognizing there are structural barriers in place because of historical and present barriers to housing, food access, public safety, environment, neighborhood development as sort of the 5 most root areas, along with access to healthcare and then access to public health decision-making, and set these goals up as what we wanted to work on together as a city with all of our partners. And so then COVID came, right? And we were supposed to launch our Healthy Chicago 2025 plan, if you will, right in March of 2020, just as COVID was really hitting hard. And obviously we got very busy with COVID, but when we finally were able to take a breath a little later in the year and turn to finally sort of launching this plan, what was striking is at 6 months later, the whole country and the whole city was talking about equity and about the different ways COVID was showing up in Black and Latinx communities and in communities with fewer resources, in ways that patterns had been consistent there. If you think about things like different rates of chronic disease, being more likely to have people have severe outcomes from COVID, being hospitalized or dying. If you think about some of the recommendations around staying safe from COVID, said you should try to work from home, and you think about essential workers who are not able to work from home. If you think about crowded housing and recognizing that we were seeing that in parts of the city that had a lot more crowded housing, we were seeing much more spread. It's harder to do some of the quarantine safely. And you can go on from there, but the conversation, I think, had opened up in a way that I hope for many of you, even if you had not thought as much about health equity or inequities, I think COVID has really brought a lot of this to light. And so as we have been moving through the COVID pandemic for the last year and a half, number one, I do think it has brought much more attention to public health overall. And by public health, we are, again, healthcare is a little piece of this, but it's about the policies, the systems, and the environments that we create that allow us to live as healthy lives as possible. And we have very much tried throughout our COVID response to date, whether it was early on, very early calling out those racial inequities and saying we've got to work very closely with community leaders and experts around calling this what it is and saying, what do we need to do to address this directly, to more recently, obviously with the vaccine rollout, wanting to set very specific goals around, it's not just good enough to get the vaccine out broadly. If we're going to get past COVID, we've got to make sure every neighborhood is seeing good uptake of the COVID vaccine. And that means education, but more than that, it means what are the barriers in different communities. And so we worked, for example, sort of taking some of these Healthy Chicago approaches, we did a ranking of Chicago's neighborhoods and said, which are the neighborhoods based on these root causes that we think are least likely to access the vaccine? Things like income and education level, but also things like crowded housing, and where do we have a lot of essential workers? Where were people unable to stay home? And we used technology actually to be able to understand some of that. We looked at anonymized cell phone data to see where across Chicago were people able to stay home, able to work from home, and then use some of that in some of our modeling and our prioritization for communities. We also looked at where had COVID hit hardest and did a ranking of community areas. We called it a community vulnerability index. And then every decision really of our vaccine rollout has been driven by that index, really working to make sure that these communities that probably have the most barriers, we do the most that we can to hold vaccine for those communities, work with partners in those communities, and over deliver to try to reach an equitable vaccine rollout. The last thing I'll note is that through so much of the work that the health department has done, technology and technology innovation has been really quite critical when we think about how can we lower some of these barriers. And certainly COVID has highlighted the digital divide, and I know I don't have to tell you that. And it's been interesting to think about how do we work on that as a city, and we may have some conversation about that. It's also really pushed the health department to try to be much, modernize a lot of our technology approaches, which have not always been the most up to date. But we've thought back to partnerships that we've had, including some through Matter, where, for example, if you're thinking about safe and healthy housing, we worked to do a predictive model that said, let's actually, in a way that protects people's privacy, where in Chicago do we know that children have previously been lead poisoned? How can we take that data? How can we use technology to actually build a system so that when I am I'm a mom coming in with my infant to a pediatrician's office in Chicago, and I pull up the chart, there can be a flag right on the chart right there that says, ding, ding, this address is a high risk address for lead poisoning. And let's get the Chicago Department of Public Health out there now, before the child is lead poisoned, do the investigation, and if we identify lead, eliminate it. We've worked with a lot of our nutrition programs and other sort of social support programs to think about cutting down people who perhaps need more support, not needing to do as much of the individual paperwork. How do we put benefits more, into modern cards? How do we eliminate, again, these barriers so that people are able to access care? And the last I'll note is related to HIV. One of the most successful, I think, partnerships that we've had is if someone who is known to have HIV comes into an emergency department and is out of care, there's a way to connect the systems, again, protecting privacy, but that can alert this person is out of care with HIV, and there can be a connection in the emergency department to hopefully reconnect and get that person back into care. So these are just some examples of the ways that we already every day use technology and innovative ideas at CDPH to try to reduce those barriers that do not let everybody in Chicago have equal access to the opportunity to be healthy. And again, thank you. Looking forward to the conversation.
Great. Hey, thank you so much. It's wonderful to hear your reflections on this issue, and I think you really laid out a great backdrop for our conversation and for some of the questions. It's always great to hear you talk about these issues of equity from the perspective of the Chicago Public Health Department. And I maybe just start with that. I think about my days when I was heading HIV at CDC and coming to Chicago quite often, because Chicago was really a model in many ways, and has always been kind of ahead of the curve when it in terms of thinking about some of these issues. So just kind of building on some of the things you said, it'd be great to get your perspective on some of the things that Chicago has led in, this whole issue of health in all policies. What does that mean, and how do you think about health broadly across the different departments within health? You touched on, and somebody in the chat put social determinants of health, and as you kind of pointed out, we think healthcare is maybe 20% of what matters in terms of health outcomes overall. The rest of it is behavior and social determinants. So why has Chicago been so much in the forefront, and what's kind of the history and the tradition that you're building upon?
Yeah, absolutely. And, I really I've been at CDPH now about 6-7 years and have really learned so much from my colleagues, but also we've got amazing partnerships in Chicago, really a lot of community-based organizations and a lot of healthcare organizations here that think in a more broad way about what are their responsibilities. I think about, for example, we have examples here of hospitals that have really stood up and said, in addition to providing healthcare, I'm going to commit to hiring from the community, right? Recognizing that sometimes hospitals that may be in less resourced parts of the city don't always do a lot of hiring, or don't do a lot of contracting from neighborhood organizations that are right around them, and recognizing that offering those kinds of economic opportunities is as essential to health. And so, West Side United is one example, but there are a number across Chicago where healthcare leaders have really taken this more broad view of health. I think this health in all policies idea, if folks are not familiar with it, is I think a really important and interesting one. My opinion is that health is I think health is a human right. I also think it is one of the hardest things to argue against. In our society, we have a lot of things that we debate, but people, more than I think almost any other issue, will agree that health is a good, and that the opportunity for people to have access to good health is a right at some level. And so I've found sometimes that being able to make sure that as policies are being developed, health is considered is not as hard a sell as you might think. At the health department, we often are a convener. Public health sometimes sits a little more in the background because we know that we don't control housing, right, in the city of Chicago. We don't control a lot of the economic decisions that are made, even at the government level. But there is lots of opportunity to say, every time that we're developing a policy, as a city, but this would extend for other organizations, what are potential health impacts, outcomes? How can we take that lens and then really use it to create healthier environments? And, it's something that is now kind of in the DNA, I would say, at the health department. In the same way, every time a program is presenting, they, or sharing their work, we've set up a culture where you have to say, not just, my job is to work on, X health issue. It's my job is to work on this health issue, and my program promotes equity in this health issue in this way. And we promote policies that will promote health around my particular issue in this way. And have tried to one of the things I'm most interested in health is this idea of like raising our public health voice. And a lot of times we're seen as less threatening sometimes than some of the other partners. And I think we are able to sometimes serve as a convener and bring people together. So.
Yeah, one example of that is the work that we're doing on equitable transit-oriented development.
Absolutely.
And how that impacts health. And I don't know if you want to say a little bit about the built environment and some of that work and how that has translated in the health department.
Yeah, I think, you can really, and I really, I really like the equitable transit oriented development as an example, because it's very concrete. It's this idea of, you want to do development, you want to, transit is generally recognized as a good way, having a good, strong transit system is something that helps people, be able to access economic opportunities, be able to generally, have a healthier city in all kinds of ways. And and as you're thinking about development, how can you do this in a way that hits some of these other goals that you would have to promote equity? And it's good because it's not abstract. It's about like,
Right.
we're going to develop, this particular that's going to have affordable housing and is going to feed into transit in this way and is going to support health. And it's pulling people together who might not always think about health and who might not always think about equity, but then together saying, if we put this at the center of the decisions that we make, yes, you can still get things done that are fantastic for economic development, but have this sort of larger kind of equitable and health related goal within it. So I really, that food policy, all of these, working on equity does not mean not having development or not being able to do big things or in any way sort of holding us back as a city. It's about having just, I think in some ways, a different conversation and making sure that there are voices at the table that might not always otherwise be there.
Yeah, and so on that, and I'm looking at some of the questions in the chat, a lot of interest in, how do we think about more integration in that way? Another great example is the Housing Plus work that we've worked on together, where, it was very clear that people who didn't have a stable home were also having worse health outcomes. And by giving people stable homes, that was, a health intervention, if you will. But we also know that we function in silos, and you're sitting at a great position, among other departments within the city, and as we talk to people who are thinking about ways in which technology can be an enabler, maybe say something about integration, what you've seen has worked, hasn't worked, and where some of the obstacles are to really thinking about this, a broader framework in as far as health equity that goes beyond health and healthcare.
Yeah, absolutely. So, there's a lot of examples of this. I think you always want to start from what are the goals and how can we make these, if there's a goal that has been set that maybe has not had a particular health or equity lens to it, how can you bring some of that lens in without necessarily disrupting the overall goal? And so, to take a really concrete example, like food, for example, which is one of the things that we've been very interested in. It turns out that, the city of Chicago itself is an enormous food purchaser, right? Like if you think about, we operate the airports, right? O'Hare and all of the food that happens there. There's food that happens through, the schools and through Department of Family and Support Services. And, it turns out like the city itself does a lot of contracting and purchasing of food. And if you can say, of course, we need to continue to purchase and buy food as a city, but if you take this sort of larger health equity, how do you say, can we buy food in a way that is more local, that is more supporting of, city or at least sort of regional food structures? And even more than that, who is being hired there? How are these decisions being made? You can still get the food, but you can use that need to drive development in ways that are, that are healthy, and even have, some of this agricultural type work, which is not what people often think of in cities, but can work if you've got economic systems that are in place. And so, there's been a lot of work across a lot of different agencies to do some of that. And housing is another really good example. I mean, housing is such a complex issue. And, I think where things tend to go badly is if somebody comes in, and that would include the health department, and starts, or anybody new working on a project, and comes in thinking like you have all the answers because you're looking at something in a new way or sort of for the first time. These are complicated spaces with a lot of partners and a lot of history in them. And where I think things have gone well is where you can say, what's missing within what is happening right now. And if for house, for some of the homelessness work, like with COVID, right? We had an opportunity to say there's additional COVID funding. We know a lot of people are in shelter. We need to do some, because of COVID, we're going to need to be moving people anyway. Let's try to move people into some hotels for a short term if they're high risk. But then how do we not just do that, but turn that into actually supporting, moving folks into permanent supportive housing? housing. And how do we take that and say, one of the reasons why we see a lot of emergency department coming to shelters is because we don't have primary care in shelters. So let's like invest in putting healthcare within some of these shelters and make sure behavioral health is in there. And it's mostly about coordinating the good work that people are already doing, and then being really careful about sharing, being very generous with the fact that coordinators are not the leaders often. They're the ones that are just creating the space and helping set some agendas around, perhaps access to resources or access to policy making. But that really, I think the very best decisions, particularly ones that are going to be in a local focused kind of way, come from people who live and are going to be most impacted by those decisions, and making sure those voices are really part of it. And you run into trouble if you don't do that well. And I would say on the tech, in the same way, if you're trying to sort of design something or innovate something, if you've not had really serious conversations with the people who you imagine are going to be using this product, whether that's the end user, whether that's, if it's a health related thing, the health system or the health department, and how it might fit into other existing structures, you can do a lot of work and spin your wheels and make a product that's never really going to be used. But if you create that space to do the true listening and not come in with too many preconceived ideas about what will help, that's generally what I think we've found to be more successful. And it's certainly a tradition that I try to learn from folks who have done that well here in Chicago.
So you touched on a little bit working with the private sector in a variety of different ways, but there's several questions around how health systems themselves can be involved, how insurance, what the role insurance plays. And I think, broadly speaking, how can the non-public sector engage in this work of health equity as well?
Yeah, absolutely. And I think, again, just take a COVID example. This has I think probably for everybody, one of the things that COVID has highlighted is how fractured our healthcare system tends to be in the US. And this is something that those of you who work in health, are aware of, that you might, see a doctor in this system and go to emergency department in this system and get a x-ray in this system, and then those records do not historically talk to each other. Our electronic health records in this country broadly have been set up to be more proprietary, and although they do amazing things, they almost by definition don't talk to each other very well. And what we have seen, in COVID, for example, one of, I think, the biggest challenge to this vaccine rollout in the US compared to other countries is that we have not done very much to connect our various healthcare platforms. And so countries where I think it's quite easy to say, let me get my list of everybody over 80 and go ahead and invite them for a vaccine in this organized way. That is just not something we have the capability to do here. There is no such system. It doesn't all need to be in a national health system, but the ability to connect across and then pull when people are seeking care, pull that all together, has really been highlighted as a gap. And so, here in Chicago, working with partners, we've done, we actually passed some emergency legislation around kind of reporting and making sure that data can be secure but more connected. And really early on, we were worried about seeing what happened in New York, where people were coming into there were certain hospitals that were completely full, but the systems were not very well connected. And maybe there were hospital beds available at a different hospital, but there was not very good visibility across the whole system to know where could you send a patient. And we said, that's not happening here in Chicago. We already had some systems in place to do this, but really worked with a lot of our large hospital partners to connect some of that data with the health department, sort of as Switzerland, if you will, as we don't have any economic interest in this, but in terms of being able to share some of that data, it is critical. And I think for a lot of public health outcomes, more ability to keep data secure, which is so important, especially when we're talking about, health, privacy, and we never want to compromise that, but also making sure that there can be appropriate reporting and connection. And then also not just for COVID, for these social determinants, right? So that as, and there's been some work within health systems, within clinics, to ask people about some of these social determinants of health, right? Like, do they have enough food? Do they run out of money at the end of the month? What language needs might they have? Are there additional supports that could be needed to lead them toward health, or to help support them toward health? Also having some connection of those, and then where kind of at the city level, we're building up more of these supports, making it easier to get people some of those resources without them needing to then do a separate outreach is kind of the ultimate goal here. And I do think, COVID's going to offer some opportunities here. There's real funding for informatics, which we need. But what we've seen is a lot of people have developed, even around vaccine, there's all of these sort of separate apps and systems that have sprung up around the country. And there's one for scheduling, and there's one for reporting, and there's one for information. And boy, it has been that part has not been very successful, I would say, in our vaccine rollout, that people have had to fight so hard with technology to be able to access vaccine. And I don't want us to be in a situation like that again. I want us to really, take this opportunity to think about how do we create structures that allow health records to connect across systems and allow information while protecting privacy to be able to be used to better coordinate care, especially where people are seeking a lot of health care and perhaps needing more support. So it's a big question, it's a big problem, but we're going to need a lot of help on how to do it. And it's not been a strength of public health historically.
So, a lot of what you talk about points to systems and the importance of having systems. And, I think there's role for technology in helping to knit systems together in a variety of different ways. And, for this audience, it is a group particularly focused on entrepreneurs and people who look at technology. And again, you've kind of alluded to this, but just to say, where is technology useful and important, and where can entrepreneurs make a difference, and where is it, not necessarily a technology problem and more of a systems problem, and where do the two come together?
Yeah, it's a big question. I think so. There's a few things. At the most basic level, there's sort of access, and some of these, as an individual user, what is my experience with health, and how can technology, or healthcare at least, and how can technology sort of help with that or not? But kind of above that and bigger than that, what we have really seen. So just to help put this in context for this audience, the health department, the city of Chicago, meaning the government of Chicago, had never even worked in a cloud environment before this. I've got a lot of epidemiologists who are very, very good at data manipulation and can do really advanced things. But it had all been done on servers. And then with COVID and the huge amount of data and this demand for really daily data updates, which I love, but was very different than, typically the health department, more traditionally, we would put out a monthly report on something, right? Maybe even an annual report on how are some of these slower moving things happen. And for COVID, we were doing at least a daily, if not more than that, sort of update, and needed to have that. And so increasingly, just to be very transparent with you all, it was taking the epidemiologists 6-7 hours to run the daily data. And it was this, in some ways, it's like when people feel enough pain, there will be the real willingness to kind of make some of the, and there had been concerns about privacy. And I know that we were really behind on that, but I'm just being honest with you in terms of where kind of government in a lot of cases will sit. And so we worked really closely, Rush University in particular, with some other partners, really stepped up and said, as we were wanting to do more of this connection, and real high level data connection across health systems, we didn't really have the technology set up to do it. And, they helped fill some of that in, but we're in the cloud, and, it's taken 5 minutes for my EPIs to do that very basic data analysis, which frees up their time to do some of the more advanced work that we want to do. But I think also we have just invested a lot of time, and not just us, but it's been a major conversation in public health departments across the country, how much time and resources everybody has been investing in solving the same problem over and over again. And I think, we worked with Google, we worked with Salesforce, we've worked with a lot of really larger players. But in terms of thinking of this as a larger kind of national strategy, especially on vaccine rollout, that just was not there, just to be honest, and in a way that I think it would have really helped everybody to not be trying to solve the problem individually. And, you see, for example, even now, and I don't know, people are in different places, but if you try to get a vaccine, the pharmacies are national chains, and so they have all set up their own systems for finding a vaccine through CVS or Walgreens, for example, which is not typically connected to how different states or cities may be running theirs, which also may not be connected to how health providers are. And we've worked with ZocDoc and others to try to pull some of this together, and have really appreciated a lot of the amazing tech work that folks have done. But I don't think this has gone very well. And I am very interested, in terms of being more prepared for whatever's coming down the line, and in terms of being able to meet these kinds of public health goals better, in people thinking about not just developing a program, but how to make something that is interoperable across a lot of different systems, including systems that are older, right? Some of the state immunization registries are really built on some fairly old technology. And we've had problems sometimes with trying to connect some of the newer tech ideas to some of that older technology. But it's an area that nobody has any pride in public health, and really are interested in, love ideas, and kind of partnership, but would encourage people to sort of try to think quite big in terms of, can this work in highly resourced and less resourced, and by which I even just mean like government, that may have less tech resources, may not be using as many of the up-to-date as we wish we were, even as we work on that, would just be one kind of piece of advice there.
So there's lots of questions coming in, and I'm going to turn to some of these questions. One that several people have raised, the academic institutions can be real partners. Could you say a bit about how academic institutions can be partners in this journey towards health equity, and maybe some examples of how working with some of the institutions here in Chicago?
Yes, absolutely. And really, the academic partners here in Chicago have been critical, central to a lot of the most interesting work I think that we've done, often because they have more of these kind of resources and expertise than the health department often will. And so, even some of those examples I was giving very early on, a lot of the predictive modeling work that we've done, we're doing some really interesting stuff with environment, and trying to pull together kind of NASA satellite data with local data. That's being done in partnership with the University of Chicago and University of Illinois at Chicago and Northwestern. Some of the work around better linking up electronic health records has been done in partnership with Rush. We've worked with schools of public health. There's really, I would say, no large academic institution here that we haven't worked with, and in some cases in great depth. We've had people really doing their doctoral work, sometimes in about research, but also kind of research in a way that is very applied about how to actually work on furthering health goals, and particularly health equity goals of the health department. And we appreciate those partnerships and those ideas, again, especially when they're done from a place of what is the need, and really setting an objective that, because I hate seeing people do work that then doesn't turn into something we can use.
Right.
And so it's about being really careful about what is that objective, what is that timeline, and then making sure that where you're innovating and doing that work, it's sort of, perfect can't be the enemy of the good. You got to get kind of version 1.0 within a time frame that can work, and then start and then kind of build from there. But yeah, we really I love sort of a lot of that academic partnership work. I think it's some of the most exciting work that we do, and it makes me really pleased when anybody who's sort of curious about the world, right? And interested in whatever they're working on says, you know what, let me think about, some things that I've been interested in. Is there a way to, partner with my local or state health department? Is there a way to maybe say, is there a problem that you've been trying to solve that maybe, a tech piece could be part of that? I mean, even in a brainstorming kind of way. And we've done, with Matter and with some of the others, I mean, even a few of these sprints and whatnot have been just very interesting for me. Like, and people have very good, like, creative ideas, and, and we've been able to turn some of them into reality. And it's expertise that is broadly not always found. We're with some of the new funding. We're hoping to build some more data scientist work and some more, some more of that kind of fundamental informatics and tech work. But it's not been a real strength, honestly. We're very good at data analysis, but those other pieces, there's a lot of need for partnership.
Yeah. No, and I think one of the things that's coming out over and over again is how important partnership and integration is across different sectors, different disciplines, et cetera. So I think, and that is a way in that I think for people who are on the entrepreneur technology side, it is a way in, because I think this, this whole how do we integrate across different arenas is such a critical part of the health equity journey. Another part of integration is how are we integrating, if you will, with the rest of the country? Yeah. And there are several questions about how do you have these conversations with some of your peers? Where do we sit with that? What are some of the lessons learned that are shared across other health departments? And, what's been your experience around bringing innovation from other places as well as exporting innovation out?
Yeah, it's a huge conversation nationally. And I think, what's interesting is I do think, you've got to have federal standards at some level, right? Whether that's CMS, some of the interoperability things, like I'm all about those. But what we've sometimes seen, particularly in COVID, I think, is that, because it was an emergency, a tendency to kind of like add additional reporting requirements, for example. And, we saw, as opposed to investing in some of the existing structures, one of the things that was driving our hospitals absolutely crazy here, and driving us crazy too, was that it was, you're already reporting these things to public health. Here's another whole set that you need to report. Here's another set that needs to be reported. And a lot of it was being done manually at a time that healthcare institutions could least afford to be taking the time to, be reporting some of that data out. So this does need at some level to be federal, I think, and setting some standards and there's, as I'm sure people on this call are aware, there's been it's not like there hasn't been work to do this. There has been, but I do think that at the most fundamental level, there are not natural. Healthcare systems are at baseline, they're competitors of each other, right? And we are in a health system that has a lot of, for-profit entities within it, even if there are large nonprofits also throughout it. And whether it's our insurance system, whether it's our, a lot of the tech, and there's nothing wrong with that, but I think it has led to less attention to the interoperability than you might otherwise have seen, because you might, lose some of that competitive advantage, particularly. And, electronic health records have been an interest of mine for a long time, even before I was in public health. I was a full-time clinician for a long time, and my God, I must have learned 14 electronic health records, like during the time, no, I'm not even exaggerating, like between sort of med school and residency and practicing in different settings. and they were all different. None of them talked to each other. And, some of that has been maturing, but it remains just an unbelievable, I think, poor use of resources in a lot of ways where hopefully I think some more coordination will probably emerge.
Well, when I was doing medical school and residency, et cetera, we were still using pen and paper, and
Right.
doctors refused to use electronic medical systems. So
Yeah.
we've come a long way, but we still have a ways to go, I think, to really think about how technology can actually be an enabler and incentivize different ways of care, practice, and this broader approach. Before I end, because I think we're coming to end, a couple of questions came in around DEI within the health department. And I think, particularly talking to an audience where it has not necessarily been as diverse, the tech world, et cetera. How have you looked at diversity, inclusion, and equity within your own staff? And how do you think that has had an impact on the way you've done your work and how equity gets factored into things?
Yeah. No, I love that question. And, it's been one of, I would say, the hottest conversations at the Chicago Department of Public Health for a decade, and it should be, right? Like any organization that wants to be serious about equity, like also has to say, what is this about internally? And so we've worked, a few things. So Healthy Chicago and Healthy Chicago 2025, these are our sort of externally facing partner. What are we doing as a city? But we have also done very explicit sort of, strategic planning type work, which is about our internal practices that puts race equity at the center of those and sets really some fairly specific, we hired, we repurposed one of our deputy commissioners, specifically kind of chief race equity officer with a focus on internal processes. And what are we doing around hiring? What kind of barriers are there? What does recruiting look like? How do we, in terms of sort of our own processes, when we're giving grants, what kind of barriers are there? How can we be reducing that? What does it look like to have people move up within the organization? Are you tracking that? Where are you seeing problems? Where do you lose folks along the way? And who's even, who's coming in at the beginning, and then who rises to the top? And our organization is working on that. Just like I think any organization that wants to be serious about that has to talk about it, has to, start from a really clear-eyed data point on, we are, the Chicago Department of Public Health is, has, is a minority white or, fewer white employees than employees of color. But our leadership team, still has, our very most leadership team still has predominantly white, although we're working on that. And being honest about that, what does that look like? How do we expand that? And why, wanting to be really set some explicit goals that can be difficult conversations, and as a white woman, leading this organization, it's something, I think a lot about, and I try not to shy away from the difficult conversations, which I think it can be easy to do. COVID has really highlighted, like literally, like we talk about this every single day all the time. And so it's been, it's been good, I think, to sort of challenge what do we do as a department to really live out the things that we're wanting to do. And it's already led to a number of changes and things that we're wanting to really do across the whole city, especially around recruitment, professional development, advancement, and then like intern, it was very hard to pay interns. Okay. It's very hard to pay interns. And we said, it's no good. Like if you're only taking interns who can afford, right, to take a job for free, you are cutting out a whole lot of interns. And so we fought really hard to change some city processes and rules and be able to like pay interns, for the work that they're doing. And then have worked hard to fill those jobs with, people who are coming from underrepresented neighborhoods in Chicago. And we want to keep those. I mean, it's that kind of like structural stuff that you really have to go after and be serious about.
Well, thank you, and thanks for that. And that's a great closing comment, because I think it's something we all work on. And I think, I just always applaud you for the intentional way that you think about your organization, but also you think about your mission and your mandate for health equity in its broadest form. So really appreciate that. And I will just say, as a Black woman heading an organization where the majority of my senior staff are people of color, we're still going through a lot of those issues as well. It's a journey, it's not a destination, and it's never done. So, I think it's something we all continue to work on. So again, thanks. It's been wonderful to be in conversation with you as always. And Steve, I turn it over to you.
Well, thank you so much. Thanks so much to both of you for sharing your perspectives. I'd like to close it out with just a really quick, just lightning question as people are thinking about their own health equity journeys and what they can do to advance health equity in their places to work or in their lives. What is one thing that they can do to advance health equity and facilitate change? And Dr. Gayle, I'll start with you, and then Dr. Arwady, close the program with you.
Yeah, I guess I would just say that, and we were just on a panel together where one of the panelists talked about the fact that we're all part of public health wherever we are. And I think people recognizing that as employers, as people working in a broad range of sectors, all of those things have an impact on health outcomes. And we should all think of ourselves as being part of public health from wherever you sit. And I think if we all do take that mindset, all of us can do things that further health equity.
Yeah, and I would just add, if you are in Chicago and you're not familiar with Healthy Chicago 2025, Google it, download it. There's links there. We are always interested in actually, pulling folks in who might be interested in being parts of committees and discussions. But if you're not in Chicago and you're interested in this, and it's been I've been half trying to watch the chat, and I can tell it's a really motivated, interested group. I wish I could talk all day and get ideas from you, but I would really encourage you to try to get connected with actually your local public health department. We are interested in your ideas and in your thoughts and in your help. Again, there are, I think, some pretty exciting opportunities, no matter where you are, to work on health equity in ways that can be interesting for you and sort of part of the larger structural things that we all need to change if we're going to be serious about advancing health equity as a country.
Thanks again to both of you, and thanks to everyone for joining us today. I hope you'll stay tuned for the next program in this series, and I hope that you all enjoy the rest of your day.
Thanks.